Hi everyone, I'm here to talk about oxygen devices that we use here at West Suffolk Hospital. They might vary from trust to trust, but actually the principle is just the same. So we're going to start with our nasal specs here, which is the most common one that you'll see. Quite a long clear tube. Now this delivers between 1 and 4 litres of oxygen. Latest BGS guidelines, they talk about 5 or 6 litres, but in this trust, just 4 litres. So room air 21%, 1 litre is about 24, 2 litres is about 28, 3 is about 32.
That's right.
Thank you. And 4 is about 35%. So they can deliver quite a high amount of oxygen. And how they work is you attach them to whichever oxygen device you have. Now some wards have walled oxygen throughout the ward, some only have half, some only have cylinders. It's not in every ward that we have walled oxygen, so just be aware of that. You attach it to whatever device you've got and turn your oxygen up. And that fits on your patient, excuse my back. You've got your nasal prongs here. There's a little plastic bit which sits on the nose. It hooks around the patient's ears and down. And there's a little toggle there that just enables you to adjust the size. The benefits of these are quite a high amount of oxygen that can actually be delivered. It enables the patient to talk, to eat, to drink. Some of the downfalls is you can't go any higher than 35% oxygen. It can cause pressure damage on patients, sort of at the face and behind the ears as well. And for patients that suffer from things like epistaxis or nasal polyps, they're very, very uncomfortable and they do increase that risk of bleeding. So that's something to be aware of. But that's the most common thing you'll see. So from there, I'll just talk about our oxygen tubing itself. It's green. There are some areas, A&E especially, that it comes in a package like this, and it's just a small oxygen tube with the same device on each side, and then that attaches to whatever oxygen device you're using. But actually, the general wards don't have that. They have a box of tubing like this, and it's bubble tubing. So it comes in different sizes depending on what mask you want to put it on, or depending on what oxygen device you want to put on. It's a bit thicker there, and you cut it like so. And again, that will attach to your oxygen mask, and then attach to your wall. As you can see, that's quite short. You want it long enough that the patient can be comfortable and move around, but not too long so they can't escape from the ward. Not to be confused with suction tubing. That comes in a similar box, but it's different. I think it's bubble cut, but it's thicker and it's clear. So sometimes you might see people with that, which is not the right tubing, so change that if you see that. Next mask that we have is a Hudson mask. You don't see it a lot on the ward. We tend to use it in theatres and recovery as patients are waking up. It needs the minimum of 5 litres to be delivered through that, otherwise it's just not effective at all. So patients, the nurses in recovery tend to wean them down to something that the nurses in the ward will recognise. But if a patient does come to the ward with that, that's what that's called, Hudson mask. And again, that attaches to your oxygen tubing and then to whichever device that you have. The next mask we have, which is one that you will commonly see, is a universal mask. And this attaches to loads of different things. You can attach it to ventilator tubing. I don't know why I'd want to do that, but you can. Most commonly you'll see it with the nebulizer attachment, and also can attach to things like filters, so it's quite good. But you'll commonly see it used, and we commonly use it on the wards with our Venturi system. Again, this is a good way of delivering oxygen. It's in nice colours, and it goes from about 24%, yeah, that's right, 24% to 60%. Some trusts have an orange one, we don't. So that's our range of colours. And how it works is it's quite specific, it delivers that amount of oxygen. So it will say on the side, we also have a different brand in the hospital I've seen recently. We ran out of these in COVID, we've got a different brand in, but it still has the numbers on the side. So it'll deliver 24% oxygen, but you need to put 2 litres through there. If you want to increase, for example, our 60%, we can deliver 60% oxygen, but it has to be 15 litres. how that works is it attaches to your mask, attaches to your tubing. Let's cut slightly short that one. It goes on the patient's face. That goes underneath the ears, which is quite a new change because we were getting lots of people with pressure areas behind the ears. So it goes underneath so the nurse can keep better eye on that. It fits on their face. If you need to adjust the size, there's these little toggles here. And then you attach that to the wall to however many litres it says. If you want to wean down, you work your way through the system. Benefits of those: deliver a high amount of oxygen if you need to. The downfall is that they can be very, very drying. So if your patient has a pneumonia, any secretions that they might need to cough up will just be dry quite quickly with these. That's always important to bear in mind. If your patient's sick and you know that you can't wean them down past 60%, you might be able to get the help quicker that you need from your specialist areas like your respiratory team or intensive care unit. The next device that we have is our NonRebreather Mask. It's what we use in emergencies, okay? And how this works. It has a reservoir bag at the bottom. Now, quite often in things like Casualty and Holby City, you'll see the bag isn't inflated, and that can almost suffocate our patients. What we need to do before we put it on our patient is turn it up to 15, nothing less, only 15 through these. And there is a valve that we put our fingers over and hold it until that bag inflates. We then put that on our patient, the same principle as the other mask, down underneath the ears, over the face, and get a seal there. And you can imagine if our patient's short of breath and struggling, if we don't fill that bag and they're sucking in, they're going to be getting no oxygen at all. We also enables us to mix the room air because there's little valves on the side there. So really important that you fill it up. Short term only really. If your patients become very unwell very quickly, pop this on in an emergency. And then again we can wean our way down or transfer our patient to another area. Downfalls of these, again, the same thing, they're very, very drying, short-term use only. If your patient's needing this amount of oxygen to keep their saturations up, they can't eat, they can't do anything with this. After this, we move on to things like non-invasive ventilation, our CPAPs and our BiPAPs. Now, they have to be done in specialist areas like the respiratory ward or intensive care unit. There is also nasal high-flow oxygen, which is humidified, which is perfect for our pneumonia patients, but we haven't been able to use that with COVID, unfortunately. But hopefully that's something that we might be able to start using again. And that's just some of the simple devices that, as I say, they do go up a little bit higher all the way to ventilation. In our Zoom sessions, we will talk about how much oxygen we give to patients and why, and how we wean our oxygen down, but we can talk about that another time. Thank you very much.